Invitation to speak. I thought I would really kind of cover a topic which is relatively emerging, even in the UK at the moment. So what I wanted to cover really are procedures that we are considering or placing under the umbrella of structural intervention, and how potentially there is a creep of using these procedures in patients with congenital heart disease. So certainly in the UK, when we are discussing patients in our meetings now for decision making, we're starting to recognize that there are some situations where a minimally invasive approach to a procedure is much more preferable than doing open heart surgery. And when you think about things like, for example, the TAVI procedure or the edge-to-edge procedures in the AV valves, they were very much reserved for patients who are older with lots of comorbidities. And even if the age range where we are performing these procedures is coming down, it's certainly not coming down to patients in their 30s or 40s. But the patients with congenital heart disease present a specific problem in that they have already had multiple sternotomies, making the surgical risk of re-entry higher. They may have high-risk anatomy, which means that if you put them through open heart surgery, their risks are higher. They have been sensitized in many ways through multiple procedures so that their HLA typing means that if you put them through more operations, their chances of getting transplantation are lower. In an aging population with congenital heart disease and increasing comorbidities, we're starting to see more obesity and things that make their surgical risk higher. So all of these things are starting to push us towards thinking, could we do things through minimally invasive approaches? Now, there are certain things that are a hindrance. We don't really have any data in this population of patients. But what I've started to realize is you don't need to go for a perfect result. So whereas a surgical valve replacement or, for example, a mitral valve replacement may give you what you think is a perfect result, sometimes making the situation better is enough to take the edge off the problem. So I wanted to start off just by sharing a list of, this is just straight off a patient note. So this is the typical kind of complex congenital heart disease patient that we look after. He's somebody who's now 35, who has pulmonary atresia, intact septum. He's had a valvotomy, BT shunt, angioplasty. You can see the list of procedures. The last kind of invasive procedure he'd had was a tricuspid valve replacement. He has a 1.5 ventricle repair. You can see he's had a Glenn in 2001. So he's had a tricuspid valve replacement with a 27 millimeter tissue valve, and he's had a pulmonary valve replacement, and he's now developed severe bioprosthetic valve degeneration. And this isn't emerging, this isn't new. A valve-in-valve procedure for somebody who already has a stented tissue valve in place is pretty standard practice. And I would highly recommend that you look up this app on the right. There's Vinny Bapat, who's the guy in the picture, used to work at St. Thomas's and he's now moved to the States. But he devised this amazing app where you can look at the stented valve that you have, and from that you can tell which valve you should be implanting inside. It's very straightforward. We look at the app, we find the valve, and we implant the valve. And as you can see there, we're implanting an Edwards valve, so it's a 29 millimeter valve inside the existing perimount valve. Sometimes you can actually break the valve ring if you want to put something bigger in, but we didn't need to here because he's got a 1.5 ventricle repair, so that is a pretty good result. So this is established care, but I will now move on to what is more of an emerging kind of care. So what types of structural interventions do I want to talk about? I want to talk about TAVI, and I want to talk about edge-to-edge repair. And in a year where Alain Cribier died, who is really the founder of the TAVI procedure, I think it's worth mentioning that this is the man that has allowed all of these things to kind of grow to the level that there are now. And the TAVI valves are essentially either self-expanding valves or balloon expandable valves, and they are very well established in their use now in older patients. And I'll show you some examples of their use in patients with congenital heart disease. And we can't mention edge-to-edge repair, I think, without mentioning this Italian surgeon who is Alfieri, who devised this process of thinking, we don't have to repair the valve fully. If we stitch the middle of the valve and turn it into a double orifice valve, we can get good results. And that's where this MitraClip and TriClip procedures came from, just this concept of the Alfieri stitch. So this is a publication from my center really about our first experience of using transcatheter aortic valve implantation in patients with congenital heart disease. And we published, I think this was the first 13 patients that we did. And this was a publication a few years ago. And since then, I'd say that we have about 50 patients or so now in whom we've performed the procedure. And there are a lot of things you need to think about when you're about to kind of consider TAVI in these patients. And our first 13 patients were patients that were predominantly, if you look at that list, were patients who had either, we excluded anyone who was just a bicuspid valve. So these patients had real complex congenital heart disease. But most of them were patients with coarctation of the aorta and the bicuspid valve that had degenerated. And you can see that that's pushed the median age up to about 67. But within that population, you can see that number 1, number 3, and number 6 are really quite complex. So number 1 was an atriopulmonary Fontan patient who had a bicuspid valve who had degenerated. Number 3 was quite an old patient with CCTGA who'd done very well for a very long time and then had severe aortic stenosis. And the last patient, number 6, was a Fontan patient with double inlet left ventricle who had a combination of severe aortic regurgitation and a bit of aortic stenosis, who ended up having quite a high risk TAVI. So this is our initial experience. And these are just some images from that publication. These are images from the patient who had the CCTGA. And it is, in some ways, a straightforward TAVI procedure because you're implanting a valve into the aortic position in somebody with 2 ventricles. But there are some things to consider here. You can see clearly in the picture the CCTGA anatomy with the relationship between the pulmonary artery and the aorta being more anterior. But you can see that in the outlet from the right ventricle to the aorta, because there's transposition, there's a lot of muscle. And that muscle in the outflow tract has to be considered when you're implanting the valve. And this shows the self-expanding valve once implanted. But actually, the positioning of the valve was a lot more technically challenging than if it had been in your aortic valve connected to a left ventricle. You don't have an infundibulum, you don't have muscle. So that's one thing to think about. I showed you that about 10 of those 13 patients had coarctation and other things like that. So when you have a previously repaired coarctation and you're about to embark on a TAVI procedure, you just need to think about the access because you're going to have to cross that site of the previous coarctation repair. And you can see an example here of somebody who's had a previous coarctation repair, and you get a lot of calcium buildup, and particularly if they've had Dacron grafts or Dacron material in place, you start to get a lot of calcification. But from our experience, the sheaths, the delivery sheaths for TAVI systems are actually quite easy to get through things like that. But this was somebody, for example, who had a coarctation that didn't need intervention because he didn't have hypertension, he didn't have any issues. So we'd never intervened on this coarctation. And in this patient, the trans-axillary approach was used. So the subclavian approach was used, and you can get percutaneous access to the subclavian artery. You can suture it afterwards with minimally invasive sutures. So this patient had access through the subclavian. And in this patient, you can see on the image here, this was an apical approach. I must say we don't resort to the apical approach very much at all, but planning your access is an issue. And all patients getting TAVI, whether they're congenital or not, they get CT scans from the neck all the way down to the femoral artery so that you can understand which vessels are available for you to access. Another thing you need to think about is spacing. Now, if you're kind of aware of the TAVI world, there's always talk about which patient is going to need pacing after the procedure, and there are predictors for who's going to get pacing. And patients with self-expanding valves are a little bit more susceptible because the valve still, the nitinol continues to grow, and that can sometimes impinge on the conduction tissue. But this is the lady who had the atriopulmonary Fontan. And you have to pace to deliver the TAVI valve. So this is pacing through the coronary sinus. But immediately after deployment of the valve, she was in complete heart block. And she ended up having to have a permanent pacing system. And if you are planning a TAVI procedure and you don't have a strategy for how you're going to pace them, so if they're a Fontan patient, how are you going to actually pace them? You have to plan all these things ahead of time because there's a very good chance you may end up needing to pace them. So moving on to the edge-to-edge repair, which patients are going to benefit from this edge-to-edge, this type of Alfieri stitch that we can deliver percutaneously? And I've split them into patients with a biventricular circulation or a single ventricle circulation. And of course, with congenital heart disease, there are so many possibilities. You could be clipping the mitral valve in a systemic position. You could be clipping the mitral valve in a Fontan. So there are all sorts of possibility to what you will end up clipping. But essentially, you can clip the mitral valve, you can clip the tricuspid valve, and there is dedicated equipment for that. But I will show you an example of clipping of a common AV valve. So the ones in red are examples of patients that we have performed in our center. Now, TAVI in our center for patients with congenital heart disease is really pretty well established. The edge-to-edge repair, I must say that we're only starting to really think about it and use it. And all of our experience has been in the last 18 months or so. So these are some, just some publications that I'll show you some examples from afterwards. But you can see that in the publications, a lot of patients with CCTGA have been in need of clips, because as you recognize, patients with CCTGA will end up getting a lot of tricuspid regurgitation. And the mantra was send them for tricuspid valve surgery. So we may have something here that may avoid having to do tricuspid valve surgery in these patients. So a lot in the systemic right ventricle type of situation. And in the systemic left ventricle, clipping the mitral valve, even if you've got clefts and things, is now possible. And this is from the French publications that I showed you, just showing their experience. And France seemed to be kind of leading the way in at least publishing what they're doing, rather than maybe not. So these are some case examples. This is actually the first patient we started off with, which happens to be the most complex. And this is a young woman who ended up having a Glenn procedure. She never completed her Fontan because her pulmonary veins had become obstructed. She wasn't a candidate for completion. So she now just has a Glenn, has a single ventricle AVSD, and had developed plastic bronchitis and was not doing very well at all. And the reason was she had this problem here that you can see. And you can see, well, it doesn't play anymore, but there was severe AV valve regurgitation. And you can see that that's a serious problem. So this is actually the clips. So she had 3 clips positioned, and I hope you can tell that the degree of AV valve regurgitation now is significantly improved compared to before. You can see that there are 3 clips in place. So one clip went in, this is the first clip, and then the second clip went in, and you can see that that second clip is moving in a very funny way because that clip dislodged, that came off. It didn't grip 2 leaflets, but it was attached to 1 leaflet. So it's moving freely with 1 leaflet. So she ended up getting the 3rd clip. So these are tri-clips used in this AV valve. And we didn't make it perfect, but we actually made it good enough for this patient who we probably performed about 18 months ago to not need a single hospital admission since then. And she'd been in hospital probably for the majority of the year before. So it was good enough to help her. This is another example of a patient with a bicuspid aortic valve who'd had end-to-end repair of his bicuspid aortic valve, had developed a combination of severe mitral regurgitation, heart failure, was being worked up for surgery, but in that period of time came in with hemoptysis and had a pseudoaneurysm problem around this. So we ended up kind of starting to think, okay, well, we're now going to need to do this percutaneously. So we put a stent graft to stop the hemoptysis and still thought that he would be a candidate for surgery. But our anesthetists weren't very happy at all because he had, you can see his x-ray shows, that's the stent graft now in place, but you can see there's a lot of pulmonary congestion there, and you can see the flail mitral valve and severe mitral regurgitation. And this patient ended up getting, that's his stent graft in place, and you can see the clips being positioned there. And this is just 3D echo showing this, the clip going in and less regurgitation. So all I'm trying to show you really is the possibility of these procedures in these patients. And my final patient is the 74-year-old who'd had this repair of inferior sinus venosus defect, but still had residual PVD, which was driving right heart enlargement, massive heart, came in extremis, almost dead, went to ITU. We could see that there was severe tricuspid regurgitation. We did a flutter ablation procedure on her, and then we thought, we're not going to get her out of intensive care without doing that. And she ended up getting 2 tri-clips. And you can see that we've only made really, we've taken it from torrential TR to probably what's moderate to severe TR. But again, that allowed the patient to progress in her hospital course and improve. We have not performed this in a patient with a Fontan circulation, but I found multiple publications that show that this is possible. And this is very exciting because this is certainly not a group of patients that you want to be taking back to surgery if they have severe AV valve regurgitation. So again, a couple of case examples of clips being performed through transbaffle puncture into either a mitral valve or a tricuspid valve if you're dealing with hypoplastic left heart syndrome. So really to summarize, structural interventions are becoming established practice in patients with congenital heart disease. We don't have any consensus documents, so really it has to be a patient-by-patient decision in a multidisciplinary fashion. But you have to think that these are options because we are starting to be able to offer this. And I think the learning for us in our first few cases is that it doesn't need to be perfect. Even if you make it just a little bit better in these patients who have very few options, it makes a remarkable difference. And hopefully there will be an expansion in the use in the future. I certainly see this becoming mainstay practice. Thanks.
Thank you, Fernando, for this interesting talk. I have a question about patient with congenital corrected TGA and systemic implanted gas. Most of these patients have systemic dysfunction, systemic dysfunction. And we have any data about this group, clipping of this group of patients.
I don't have data. We've never done one in Bristol, but you can see from the French experience that they've done quite a few. I think that this patient population, if you look at the data that guides us as to when to do tricuspid valve replacement, it's clear that if they have severe TR and the ejection fraction is more than 45%, they should go for surgery. If the ejection fraction is less, you're starting to think about transplant becoming their option here. And we can sometimes think of transplant as the first option. But what I think this opens up is the possibility of actually clipping these valves to see how much of an improvement you can get in ventricular function. You have lost nothing because you've not done a sternotomy. You've not sensitized them in, so their transplant risk, their transplant chances don't change at all. So I think this is going to be a huge group of patients that we start to offer this procedure for in the future.
What is your prerequisite for the clip? Where do you put the clip?
I think the prerequisite, now what you need to recognize is that you have to work very closely with people who do this all the time. So there are, our interventionists that do mitral clips will do a list every single week. So the prerequisites have to do with the leaflet tissue, the length. You have to have enough leaflet tissue to grip. So it's, you can't clip deformed or retracted. So if somebody's had AV septal defect repair and the valve has been repaired and looks horrible and short, you have to have tissues to be able to grip.
And if it dislodges, where does it go?
Well, if it dislodged like the one you saw, if it's clipped onto the leaflet, it's fine, it's attached. Well, if it dislodges حتة تانية, you go get it.
Let me ask you about your TAVI experience, because I noticed the patients are 50-something. Without age, but age had updated.
Yeah, so
It's not the usual for a regular TAVI.
no, it's not. And
The general disease, do you go down in the age?
we do.
What is your limit here? I mean, what is the limit?
We don't have a limit. I mean, I think it depends. So we've had, for example, we had quite a practice where we had women with, let's say, bicuspid valve. They had aortic valve surgery who ended up getting tissue valves. Now, tissue valves in young patients are really bad, so they degenerate very, very quickly. So you already have a woman you have a woman already in childbearing age with a degenerated tissue valve, one sternotomy, and her options really are to go for surgery and get a mechanical valve or get a TAVI valve in valve. And in those patients, we've been offering that as an option to just really defer. Yeah.
What do you expect the future will be like?
I mean, we have data that shows that TAVI valves are relatively durable. We don't expect this to be the end procedure for them. They are expected to have more procedures. Now, if the surgeon had gotten a big valve, you can do TAVI in TAVI, but you get to the point where you can't just keep landing valves inside. But for a woman like that, what we would be hoping to do is get her through childbearing years and then offer her a mechanical valve in her 40s.
It will be easy to have a valve and then valve with, I mean, a biopsy valve and then a valve and a TAVI valve and then for surgery.
I think the surgeons don't think it's a problem. If you have two valves in, but they just take the whole thing out. So I don't think they think it's a problem, no. Yeah. But
Maybe the problem facing the pulmonary
Yeah, so one of the things, the problems with TAVI is that you challenge access. So let's say we do all these TAVI procedures in young patients and they end up getting acute coronary syndromes when they're in their 60s. Engaging the coronary arteries in someone who has a stented valve is difficult, and sometimes you can't even. So you have to consider all of these things but I think the liberation of congenital heart disease, sometimes we're actually dealing with patients with survival options that aren't that long. And as I said, we don't have fixed rules. Every single patient just need to think about the details of what you're deciding. Even yes, I mean, TAVI valves impinge on your access to your coronaries. So yes, that's something we think about. You're welcome.
TAVI in structural heart disease or congenital heart is considered as a bridging procedure, or it is life-saving while you are thinking about TAVI in congenital heart disease. And what about the position in anterior position of the aorta? If you have correct transposition.
Yes, so we showed you a patient where he had transposition. So I think the aorta within the chest is not a problem. TAVI as a mechanistic thing is quite simple. You're just landing something in a tube. Why are we doing it in patients with congenital heart disease? To potentially avoid another operation. Is it definitive? No. What we're doing is either, you saw our population of our first TAVI experience, they're quite old. So in them, we are probably looking at a definitive procedure. That Fontan who was in his 20s and got a TAVI valve, I don't think he's going to live for, till his 60s anyway, so maybe definitive. In young women, we may be doing it as a bridging procedure just to delay surgery. So it varies by patient by patient. I'm not saying this is for everyone. Definitely, we send a lot of patients with congenital heart disease and aortic stenosis to the surgeons. But I think we're now realizing that this is just part of the tool set that we have, and it can be very useful for some patients.
What about the patient with Fontan and plastic bronchitis? When you give the valve, did the bronchitis go?
We have her. No, so she was very well managed. I mean, her bronchitis, we had her on just the usual things that we would have patients with. She wasn't. So she was under control. We're not curing her, but as I said, she was in hospital for most of the year before she had the clip, and she has not been hospitalized since then, which for us I think is good. Yeah. You take the edge off. I think you just take the edge off the problem. Yeah. I think so.
Actually, you should not leave the patient if the symptoms and severity of TR is so significant, we go for MRI and very full evaluation. Right, the volumes and function suitable. Here we go for tricuspid valve repair or replacement if you can't do replacement. That is my problem. If the problem is when you have this maker, we can't go for MRI.
The issue is when there is severe systemic systemic
If we were at the MDT and we had someone with severe tricuspid regurgitation, a good ventricle, we would still send them to surgery. We wouldn't do a triclip. But if you had ventricular dysfunction, the outcomes from surgery are borderline. So in that case, if I was deciding, I would probably opt for a clip and then see.
So you have cutoff value for the early function?
40, 45, there's a big study that looked at the numbers, 40, 45.
But actually, I have cases after repair or replacement of tricuspid valve improved.
Of course.
And the right ventricular systolic function. True. My question for you, Dr. Adwa, about clip in cases of AV canal.
Yeah.
You know that it's 5 people superior bridging between both superior and inferior.
So I mean, I think getting your head around which leaflets you're going to be clipping is very, very difficult. But you need to kind of clip an anterior and a posterior leaflet.
Guided by TE.
And intracardiac echo. If you looked at that example, we had intracardiac echo and transesophageal echo at the same time. So you can understand.
And now it's my honor to introduce the next speaker, Dr. Makram Abid, طبعا well known to all of us. He is a professor of pediatric cardiology at Massachusetts University, USA. Dr. Makram, تفضل.
Thank you, Dr. Ahmed. Thank you, Dr. Mai, for inviting me. It's really a pleasure to be here It's a long trip, but it's worth every minute to be here and be with friends. So my talk this afternoon is about catheter intervention as a rescue post-operative procedure. I'm going to try to address a number of issues. So many things we consider when we're talking about these patients. They are usually critically ill. They're usually on drips, which have to be maintained accurately. Mechanical support is a question which comes up whether they are in mechanical support while you're doing it, or do you need mechanical support to be available? Or these patients are really a candidate if you cannot successfully do the procedure to do anything else. So all these questions need to be addressed in advance. So we have a lot of discussions, as Dr. Rod was alluding to, with multi-specialty discussions. What are we going to do? The surgeon, the ICU, the surgeons, the anesthesia, the cardiologists, and above all, the parents. What are their expectations? If things go wrong, is this kid a candidate for transplant, or really we don't have a whole lot to offer? And then you're planning the procedure. A lot of times the surgeon or the intensivist will tell you, just go in, check for us the blood gases, for example, or the filling pressure. And you say, yes, but in your mind, you need to be prepared to surprises. You need to figure out that many other questions are going to come up if this patient is being referred for urgent intervention as a rescue procedure. And I'm going to try to show you, if we have time, some of these examples. Froze. Access issues. These kids are going to be on drips where there is a lot of lines, and sometimes these lines are occluded, or you don't have the regular access. So all these things you're going to have to think about in advance. Do you have a chance to get more imaging, or is the kid so unstable? Can you get CT? Can you get an MRI? Or you're going to accept what you have? So with all this in your mind, you're going to go to the cath lab. This moves. And be prepared for the unexpected. So I'm going to talk a little bit about some of these patients and what surprises we had and what not surprises we had. So this was a newborn heterotaxy syndrome with a single ventricle. It's not very clear here, so I hope you can read it. Pulmonary atresia, had obstructed infradiaphragmatic pulmonary veins, right out of the arch. This kid generally could be considered non-survivable with all these obstructed veins, infradiaphragmatic, single ventricle pulmonary atresia, but we choose to offer everything we can before we say that the kid is not survivable. So the surgeon underwent the repair of the total anomalous pulmonary venous return, placed a shunt, but the kid was very sick and could not be coming off the ventilator, and we were asked to reassess the patient. Echo showed that there was severe pulmonary vein stenosis after a few weeks or really a few days of this surgery. So you can see the baffle, and there is a high velocity flow through the baffle. The gradient was 34 millimeters. So that in a way, we said, okay, we can go maybe make this kid better. But as I alluded to, the kid was very sick, on very long in the hospital, and now we go in and the pulmonary veins are occluded, and the femoral veins are occluded. So now we had to switch to a different approach. So with that, we decided to go to transhepatic to address the baffle. And once we cross, you can see that the baffle itself is the dye sitting there, so clearly is obstructed. We went ahead and used the cutting balloon, and it really opened it quite nicely angiographically, and pressure went down from 23 before to 12 after. And the baby did very well. I'm showing this picture actually with the permission of the mother, because it sends the home message that sometimes we think of the heart when you don't think of the whole child. So she took pictures of this baby when he was very sick after surgery and after cath. And then this after the kid had a gland, and this after the kid had a fontaine. Very beautiful, cute girl. And the mother wanted me to share this with you. So a lot of times you do go the extra mile, but it's really very rewarding. This was a 3-week-old hypoplastic total veins, renal anomalies, had again repair of total anomalous pulmonary venous return, underwent a pulmonary band. He could not be considered a good candidate for a Norwood. So with this, we were asked to help with preparing him for a future when he could be a better candidate after the renal failure. So we went ahead, and this kid had aortic atresia, so really it's a very high risk stenting of the ductus, but it was discussed at length that there is no other options. So we chose at this point to use a self-expanding stent, which maybe it offers less pressure if there is but these are very selected cases that generally you hope for the best. But my choice for this one was a self-expanding stent, and that was the aortic atresia, but the kid did very well and eventually underwent his Norwood successfully. A few weeks later, he underwent the Norwood with a Sano. Everything by echo looked good, but the kid had could not be weaned off the ventilator and persistent callus effusion. So again, we were told to just go ahead and see the filling pressure and see what we can do. So as we're getting pictures, the innominate vein was practically occluded, and that was probably one of the reasons why the kid had so much callus effusion. So we pushed a very tough wire, and then the balloon used to milk back, but this is a guide catheter pushing the balloon to avoid it milking back. And then after we were done, there was reasonable now flow, and we looked at everything. The left pulmonary artery was a little narrowed, so we went ahead, and in the interest of time, I'm going to move a little fast. We went ahead and ballooned the left pulmonary artery, and that was after we were done. And the baby's callus effusion decreased from around 100 per day to 20 the day after, and then became completely dry and did very well. And this was a cath after, when he was before having the gland here, he was presented to the clinic kind of blue. So we were asked to take cath him again. The innominate vein was open. That was not a problem, but there was narrowing in the sano proximally. And so we decided to stent it. And of course, we expect the CES to drop, but we always tell the anesthesiologist we expect at this point, so don't panic over it. And we went ahead and stented it. And that's after the stent. And the baby did very well after that, underwent his gland and subsequently the Fontaine at the scheduled time. 2 months old, hypoplastic Sano, multiple PICC lines, rocky pre and post-operative course, significant desaturation, required urgent intubation, was taken to the cath lab also urgently. Again, somehow we got surprised many times with the occluded femoral veins. But after a while, it becomes like, okay, we know what to do. So we went from the transhepatic. This makes it much more difficult because getting from the transhepatic through the Sano is not really terribly easy because you go posterior leftward and then anterior rightward, but with the soft wires that you're prepared that you can do that, and then you can put your guide catheter. And then we got a picture, and it looked like the distal part of the Sano was a little pinched. So always the surgeon is there because this is really, even though we're doing the procedure, but it's really mostly his decision whether he wants to take the baby back or would he rather if we do it. He definitely did not want to take him back. So we wound up stenting it, as you can imagine. And then the stent is going into place and then being deployed. And second, it's this was probably a 5 millimeter drug eluting, if I remember correctly. It's generally what I use, the size of whatever Sano they have put in, and that was enough to really improve the flow. It doesn't mean that it cured this, but was Dr. Rado alluded to. It's good enough at that point that the baby was easily weaned off the ventilator. Well, they like to make it more complicated for me. So this was a 2-week-old hypoplastic left heart. Dextral rotation, underwent a Sano and could not come off the ECMO. So he came to the cath lab on ECMO, trying to assess what is going on. Now it became a little more complicated. So the right pulmonary artery looked like it's pinched and narrow. The left pulmonary artery, well, we winded up at that point very similar. I talked to the surgeon and they said, we're in salvageable state, now do whatever you want to do. To get the baby. That exactly was his words. So we first stented the right pulmonary artery, and that was the appearance after the right pulmonary artery was stented. And you have a feeling now that the left is not happy either. So that the left proximally is almost a pinhole. Distally it looks okay, but just proximally it looks like a pinhole there. So we winded up stenting it. Again, there's much better flow there. And then proximally there was also Sano stenosis, so we ended up putting the stent there, and that's during deploying the stent. And that was the final picture. There was very good flow to both pulmonary arteries and through the Sano. And the baby ended up doing very well. Within 24 hours was weaned off ECMO. Within a few days, the chest was closed and did remarkably well. Well, sometimes I cannot answer for this baby specifically, but sometimes if the sano is too short, they may pinch it, or they may have been originally or congenitally. That's correct. Well, make things also more complicated. 3 kilo baby, hypoplastic left heart syndrome variant, had interrupted IVC. Underwent stage 1 Norwood. The saturations were 60s on oxygen. So the question we asked that looked by echo, everything was fine. They said, well, maybe there's lung disease. Can you just check the pulmonary venous gas? I said, sure, we can. But of course, in your mind, you have to be prepared that this is the question they're asking, but the reality is going to be prepared to other surprises. But he has interrupted IVC. So now this is the real caveat. So I said, all right, pulmonary veins, we can just relatively easy go from the transhepatic to the pulmonary vein. From the IJ, I don't think it's going to be easy at all. So we decided to go from the transhepatic. And I'm showing this because now doing it with ultrasound is really making it much more easier. And I think it should be the standard. So I'm just reminding everybody of this. First, identifying the hepatic vein and then the needle going through. And then you can actually do it without fluoro, but you usually in the cath lab to confirm everything. So once we're there, we can get a little hand injection confirmed that we're in the right place. I know. Yeah, I got the needle we were hoping to show exactly. Dr. May. Yeah. Maybe next time. I got the needles with me, whatever we need. Next time, inshallah. So we got the pulmonary vein gas. It was totally fully saturated. That was not the question. So got the hand injection. As you can expect, there is a little bit of proximal sanostenosis, which in my mind, I was looking for it, even though the question was pulmonary veins. I knew they were going to have other surprises. So it's the same question comes up at this point. Getting to it is not terribly easy. Probably from the IJ may have been easier, but at this point, here we are. So we go with a very soft wire. And then over the wire, we go with a micro catheter just to give us more support during delivery, advancing the guide catheter to deliver the stent. So there's the guide catheter. And you can appreciate the curve it has to take, but it's not undoable. And the little hand injection, the distal PAs looked good in contrast to the other babies. So these were not the issue. Just proximity there was very mild, but it was enough to get the kid to be sick. So we ended up stenting the proximal sano, and that was the picture once we're done. And the kid went very easily off the ventilator and sets in the high 80s. This is probably, we see this not uncommon. 12 hours after a shunt, the shunt has completely occluded. It's relatively easy to address, so the wire goes through with fresh clot and then eventually stented. And that was, and again, the sets were in the 40s, went to the 80s, I believe, that day. So this was a different scenario as a sano, but there was proximal stenosis of the left and the right pulmonary artery. This I didn't think needed a stent. We used the cutting balloon, and that was used it both sides and was enough to get the kid off the ventilator. I'm going to go fast. Well, this was interesting. I'm going to just, this was a gland, but the left pulmonary artery was very small proximally. So the surgeon put a sano from the heart to the left pulmonary artery and did a gland to the right, but he left the connection. And the estimation that there was not going to be a lot of flow in between to help the left pulmonary artery grow. But reality, once the circulation was established, there was a lot of flow. And the gland pressure was around 28, and the kid was doing pretty bad. So suggestion was to put a flow restrictor in the sano to limit the flow. And I'm showing just the echo because what is pulsating right there is the IJ. So because of the flow from the sano, it was significant to the right pulmonary artery, there was pulsating IJ. So we winded up, so we just obtained the access also to do ultrasound a lot on these patients. And then what we ended up is putting a flow restrictor and the pressure. But again, this angle was quite tricky to get to the sano from the neck. And then we ended up putting a flow restrictor, and the pressure was 28, I think came down to around 18, which was enough for the baby to come off the ventilator and do very well and go home. So in summary, post-operative rescue procedures can be challenging but life-saving. Collaboration between entire staff is essential. The surgeon, the catheterizer, the anesthesia, ICU staff, ECMO team, nurses, everybody, including the nurses in the cath lab, have to be tuned to everything that's going on. Adequate supplies are needed, of course. Be prepared for surprises. It may need some innovations in the cath lab. I appreciate your attention.